Okay, so sorry guys. I was in the middle of doing my lecture and the power went out. So this is going to have to be in a part 1, part 2 type format. So you should have just finished part 1 and this is going to be the start of part 2. So I'll pick up right where we left off. And that was with this slide here. So we were talking a little bit about physical exam and the impact of pain and pain medication. So don't forget that pain can play a huge role in the depth of respirations, but also pain medicine. So the opiates and the morphine, the oxycodone, the hydrocodone that we talked about, those opiate medications, a side effect is respiratory depression. So that means decreasing the respiratory rate, the rhythm, the depth. It just suppresses those reflexes in a patient. So that is why you get people who overdose on those kinds of medications. It decreases their drive to breathe. Okay, so just keep that in mind about opiates. So again, more to come on assessing oxygenation status. So breathing patterns. So we're going to assess for normal and altered breathing patterns. So there's a variety of different kind of breathing patterns that a person can show. And here on to the right of your screen, you'll see breath patterns. So this is a really awesome visual for those visual learners out there. This shows you all the different kinds of respiratory patterns. Note, this is not all the different kinds. There are more that you'll find in your book, but this particular picture, I think, is a really awesome tool for you to use to learn and memorize these ones that are mentioned. So with these, you'll see next to the name of the breathing pattern, you'll see little doodles, and that just kind of shows you exactly what the person's respirations are doing in kind of a visual way to help you kind of connect the dots there. So we're going to talk about these different kind of breathing patterns. And again, you can find more information in your book. Okay, so Cheyne-Stokes is the first one we're going to talk about. So this is, these are Cheyne-Stokes respirations. This progressively increasing in depth and then progressively decreasing in depth, followed by a period of apnea. And apnea just means no respiration. So you'll see in that photo, that little drawing right next to Cheyne-Stokes respirations, you'll see up, down, up, down, up, down, up, down, up, up, down, up, down, up, down, up, down, up, down, nothing. Up, down, up, down, up, down, up. So it just kind of repeats that. So progressively increasing periods of respiration, progressively decreasing periods of respiration, and then apnea in between. These are typically an end of life breathing pattern right here. You'll see similar end of life breathing patterns with Kussmaul's respirations, which is something that you can read about in your book. It's not on this photograph, but I suggest that you review that as well. But again, this probably means this type of breathing pattern, the Cheyne-Stokes, means that your patient is probably in the dying process or transitioning into that process. Next, we have Biot's respiration. So these are irregular periods of inspiration and expiration followed by periods of apnea. So a lot of times we see this in some kind of like traumatic injury or a nervous system injury or like a traumatic brain injury or something. So these are those kinds of respirations, Biot's respirations, and you can see that visual there next to it. Normal respirations or eupnea. So in eupnea, EU in the medical world always means normal. Okay, so if you see the EU before as a prefix of a word, you know that that's going to be normal. And then the pnea, P-N-E-A, that always means breathing. Okay, so when you put those prefixes and suffixes together, once you see them, once you memorize what they mean, you'll be able to break down any word. Okay. So with eupnea, that just means a normal breathing pattern. So the rate is anywhere from 12 to 20 breaths per minute. And so when we get into our vital signs chapter, you'll learn a little bit more information about that. But right now, all you need to know is 12 to 20. That's your normal respirations. Okay. And then a regular inspiration and expiration. Regular is the rhythm. So what that means is it happens when we expect it to happen. So they take breaths at normal intervals and we can almost time it. Comes, it comes, it comes, it comes. Same thing with the heart rate. It comes, it comes, it comes, it comes. So we just kind of know because it's a regular pattern. Okay, we can predict that it's going to happen. Keep in mind when you're counting a respiratory rate, one inspiration and one expiration, that is one respiration. The in and the out is one. That one pair is one respiration. Okay, so don't count them separately. So 12 to 20, that's what you're looking at for eupnea. Okay, so next we're going to talk about bradypnea. And so with that, again, the pronunciation of these words, sometimes, you hear different from everyone. So The Brady prefix always means less than or low or slow. Less than normal is what it typically is. So with bradypnea, it is a regular rate. So again, it comes predictably of less than 12 breaths per minute. Okay. Next, we talk about tachypnea. So that's regular. So it comes at regular intervals, but shallow breaths of greater than 20 per minute, because that tachy in the prefix always means above. Okay. So when you're talking about tachycardia, that means a high heart rate. Tachypnea, that means a high breathing rate. Okay. So tachy is always high. You can see tachypnea in things like exercise. We know we breathe super fast when we're exercising. A fever can cause an increased breathing rate, and then fear or anxiety as well. And then apnea. This is a period of zero respiration. So obviously all dead people have apnea. Okay. But there's also other things for living people that have periods of apnea. Okay. So Shane Stokes respiration is a period of apnea. Sleep apnea, where you stop breathing for, too long, a little too long in your sleep pattern. So that would be apnea. Okay. Hyperventilation. This is increased rate in depth. Where a patient would blow off CO2, causing a decreased level of CO2 in the blood, common in anxiety, fear, and extreme exertion. Okay, so that's hyperventilation, so increased ventilation. Okay, so continuing on with assessing oxygenation status. So respiratory effort. So a patient experiencing shortness of breath or dyspnea. So when we talk about dyspnea, that's talking about labored breathing. So when you can look at someone and you can tell that they are having quite the time breathing. So breathing really heavy, that's dyspnea. Or sometimes you can see those areas in between their ribs. Just know that they're really working to breathe. That's dyspnea. Okay. So those patients that are having dyspnea and shortness of breath, they require a thorough assessment. So in order to assess them, we're going to ask closed questions that the patient can answer either yes or no to. Okay, we're going to, and the reason for that is we don't want them to talk a lot, because when they are having that hard of trouble breathing, we don't want them to overexert themselves by trying to answer our crazy questions. So keep the questions short to where they can answer with a quick yes or no. And we're going to want to know a couple things about their condition. So when did their shortness of breath happen? Was it sudden? Was it gradual? How severe is it right now? Is it getting better or worse? What helps? What doesn't? That kind of thing. We're going to assess their cough. So a cough is a normal protective response that keeps the airway clear. We love coughs. Okay, it's good. A cough that lasts greater than 3 weeks should be evaluated by a physician. And things we want to know about the cough. So is it productive? Productive meaning, are they coughing up sputum? Okay, so remember that sputum is that drainage, and that stuff that is down there in the lungs needs to be coughed up. Okay, sometimes it's green, it's yellow, especially if it's from an infection. So we want to know, is it productive? That means it's productive. They're coughing that up. If they're not coughing anything up, it's a non-productive cough. Okay. So things we want to know: what does that sputum look like? How much of it are you coughing up? What color is it? What makes your cough better? What makes it worse? Is your cough worse at any time of day? Is it worse at nighttime? What other symptoms do you have? A fever, red eyes, runny nose, that kind of thing. And then lastly, pulse oximetry. So remember, this is a non-invasive estimate of arterial blood oxygen saturation. Okay. So otherwise known as SaO2, you may see it abbreviated like that. So SaO2, you'll know if you put on a pulse ox, you'll see a percentage on your screen. So this percentage reflects the percentage of hemoglobin molecules in the body that are carrying oxygen. Okay, so a normal value is anywhere from 95 to 100% for a healthy adult. Less than 94% can be considered abnormal in healthy people and should be investigated. It's important to note that patients with chronic respiratory problems like COPD, or otherwise known as chronic obstructive pulmonary disorder or disease, typically they have much lower oxygen saturations, and that is protective for them. Okay, so a lot of times that buildup in CO2 in their blood by their oxygen being decreased actually stimulates their drive to breathe. So if you give them too much oxygen and help their oxygen saturation stay close to 100, you're actually doing them a disservice. Okay, because they need that low oxygen level to stimulate their drive to breathe. Okay, so that's important to know. All right. So moving on, this is a really nice acronym here to help you kind of remember the symptoms of hypoxia. Okay, so remember the early symptoms. So early RAT, R-A-T, so you got R for restlessness, A for anxiety, and T for tachycardia and tachypnea. So these are the early signs of these are the early signs of hypoxia. Okay, your patient's going to be restless. They're going to have anxiety. Their heart rate and their breathing rate is going to go up. If you've ever thought about what it would be like to not be able to breathe, it's going to cause panic. So that is what this is saying, those early signs: restlessness, anxiety, tachycardia, and tachypnea. So your early RAT is late to bed, BED. So B for bradycardia. Okay, so eventually, you know, your body in the beginning stages is trying to compensate, but eventually it's not going to be able to compensate anymore. That heart rate's going to go down, because what's going to happen if we don't breathe? We're going to die. Okay, so the heart rate starts to go down. So that's a late sign of hypoxia, is bradycardia. That's a low heart rate. Okay. E for extreme restlessness. Your patient's going to be extremely restless because they can't breathe, and that's very scary. And then D is for dyspnea, which we know now is labored breathing. Okay. There's also a little acronym down at the bottom for pediatric patients for fines there. You can read through that. You don't really need to know that for this class, but it is, it will help you in other classes as well. Okay. All right, let's test your knowledge. So the term Kussmaul respirations refers to a high-pitched, harsh, crowing inspiratory sound that occurs due to a partial obstruction of the larynx. True or false? So you will notice that we didn't talk a lot about Kussmaul respirations. You don't know what they actually are because I didn't go over that. And here's the thing. Let this be your warning sign that I will not put every single item from your book in these PowerPoints. I cover the cliff notes, but you are still expected to cover these things in your book on your own time in your studying. Okay. So as you read through your book, you'll find out what Kussmaul respirations are, and you'll be able to apply that to your test. So just make sure that you're also taking that step and not overlooking that. You paid for that book. You need to use it. You will have test questions from your book that are not in my PowerPoints. Okay. You must be on the search to gain this knowledge. Okay. I cannot learn it for you. So, the answer here is false. So what they're actually referring to, this high-pitched, harsh, crowing inspiratory sound that occurs due to a partial obstruction of the larynx, is actually stridor. Okay. You may or may not learn about stridor in this chapter, but once you get to your physical assessment chapter, we'll talk about that when we talk about lung sounds and things like that. So that's important to know. Oxygen status diagnostic tests. So a sputum sample. So when we're talking about sputum samples, that's that stuff they cough up from their lungs. We take a sample, they microscopically look at it, it's cultured in a lab, and it identifies the organisms, and it tests for sensitivity to different anti-infective agents so that we can get rid of whatever infection that is. Okay. Cliff notes about sputum samples and obtaining them. Keep in mind, sputum and spit are not the same thing. Having a patient spit into a cup is not going to get us the same result as having them deep breathe and take a huge breath and cough out whatever is in their lungs. Remember that sputum comes from their lungs. They have to cough it out. You cannot, a spit sample is not that. Okay, so just keep that in mind. Best time to get that is in the very beginning of the day and not towards the end of the day. Okay, so just kind of keep that in mind. Tuberculin skin testing. So this is widely used to detect exposure and antibody formation to tuberculosis. Okay. Typically, annual screening is recommended for low-income populations and patients who live in nursing homes or other congregate living conditions. A positive TB10 skin test is when you have induration, which is a raised hard area at the site of where the test was administered. Okay. Redness does not mean a positive test. A hard nodule there means a positive test, and it only means a positive test depending on the measurement and the size of that induration. We will actually learn more about this in lab, as you guys will most likely all get certified in giving TB skin tests. Okay. Pulse oximetry. So we talked about this. It's non-invasive. It measures the arterial blood oxygen saturation in a non-invasive way. Okay. Should be 95 to 100%. Capnography. So this measures the carbon dioxide in inhaled and exhaled air. Okay, directly measures that process. Normal value is from 35 to 45. You don't need to really know that. Okay, that's just kind of a cliff note for you. Spirometry. So this is a measure of air that moves into and out of the lungs. We'll talk about that a little more in a couple of slides. But that's your incentive spirometer, that if you work at the hospital or you've seen one like that in a facility, that's kind of what we're talking about. Arterial blood gases. So this is where things get a little bit complicated. And I don't really want to get too in depth here in fundamentals about this. You will learn this in a variety of your other classrooms. But what this basically is an arterial blood gas covers three areas. Okay, so it covers, it evaluates three areas. So it evaluates the partial pressure of oxygen, the partial pressure of carbon dioxide, and the pH of the blood. Okay, those three things are very important, and those three things together and those values are going to tell us, is our patient in metabolic acidosis? Are they in respiratory alkalosis? And there's a variety of different things, but I don't want to get too complicated. So I'm just going to give you the cliff notes here, but you don't need to study this part in your book. Okay, so with the partial pressure of oxygen, so this is the amount of oxygen available to combine with hemoglobin to make that oxyhemoglobin. Normal is from 80 to 100. Partial pressure of carbon dioxide. This is a measure of the CO2 dissolved in the blood. Normal from 35 to 45. Okay. And then your pH, that's your pH level. Okay. Normal from 7.35 to 7.45. Okay. And that's about as deep as I'm going to go into that with you guys. And then when we're talking about peak flow monitoring, so this like a peak expiratory flow rate, or PEFR, this measures the amount of air that can be exhaled with forcible effort. Okay, typically you see this in patients with asthma. Typically peak flow is used to detect subtle changes in their condition, often before they even experience symptoms. Okay, it's measured in liters per minute. And patients with asthma are typically asked to measure this daily and with the onset of any new symptoms. So test your knowledge. So which diagnostic test or exam would best measure a client's level of hypoxemia? So let's break this question down, because this is a good NCLEX style question. So we need to just think, what is this question asking us? So we're looking for a diagnostic test, and we want to know what would best measure the client's level of hypoxemia. So if you remember, hypo, it's got hypo, okay, and ox, so we know that means low blood. Okay, hypoxemia means low blood oxygen. Okay, emia always means blood. Okay, and the emia, that's a suffix that always means blood. So we know that we're dealing with the blood sample here. Okay, so is it going to be a chest x-ray? Probably not. Is it going to be a pulse oximeter reading? Well, that could be a contender. That's one that would probably distract you from the right answer, right? So, and then peak expiratory flow has nothing to do with oxygen or with the blood. So we're not going to mess with that. So you'd probably get yourself down to these two, B and C. And the correct answer is going to be letter C. Okay. And the reason for this is because pulse oximeter does test for a level of hypoxia. Okay, hypoxemia even, but it's not invasive. It's not as accurate. Arterial blood gas sampling is a literal sample of the blood that they test for these items. So that is the best way to measure. Okay, and that's how you can kind of work through that kind of thing. So working through the nursing process. So we did our A, which was assessment, right? So we did our assessment. Now we got our ADPI. We got to go to our D. Our D is diagnosis. Okay, so let's talk about some nursing diagnoses that would be appropriate for a patient experiencing oxygenation issues. So we're not going to go through each one of these. You just need to know these are the ones right here that are approved, NANDA approved, for patients with respiratory issues. Okay, and these are here for your reference. You can always look in your nursing diagnoses book as well, but these are the ones, okay? These are the ones that would be appropriate. And so interventions, when we're talking about our interventions, we are thinking, what are you going to do about it as the nurse? What's your job? Okay. So interventions are so important for us. And this is the basis of a lot of your NCLEX questions in this class and in this program. Okay, so interventions for optimal oxygenation. So we're going to administer respiratory medications. So these are used to improve respiratory function. Examples include bronchodilators. If you've ever heard of albuterol, an inhaler or a nebulizer, those are all bronchodilators. Okay, anti-inflammatory agents such as corticosteroids. If you've ever had such a bad respiratory infection or pneumonia that they've given you a steroid shot, that's what we're talking about here. Cough suppressants like guaifenesin or robitussin. Decongestants, things like that. Okay, these are the kind of medications that we're going to give. I want you to keep in mind that we're not going to give over-the-counter cough and cold medicines to any children under the age of 4. Okay, there's an increased risk of serious and life-threatening side effects in these patients, and you need to remember that you can give them honey instead as a cough suppressant. So you give them a teaspoon of natural honey, give it to them, it coats their throat and it helps with their cough. You do need to know that you cannot give honey to kids less than 1 year old, okay? Because it could be an allergy type of deal. The same way you don't give a younger than 1 year old some peanut butter, okay? Same kind of thing. And then use of a mechanical ventilator, that's another intervention we could use. So a mechanical ventilator is a machine that assists a patient to breathe. Usually the patient is intubated before being placed on the ventilator. An endotracheal tube or a tracheostomy tube is connected to oxygen tubing, and that kind of thing. Okay, so we'll talk a little bit more about those tubes here in just a slide or two. So other interventions. Promoting respiratory function. So how are we going to do that? We're going to make sure that we do our best to prevent healthcare associated pneumonia. Okay, we talked about our healthcare associated infections a few chapters ago, and this is important. Okay, prevent healthcare associated pneumonia. Typically, it tends to be more complicated and have a higher mortality rate than actual community acquired pneumonia. Okay, so we want to prevent that. We also want to provide lots of education to our patient about immunizations. We want to recommend that they get their flu shot every year. We want to educate them that upper respiratory infections can be viral, they can be bacterial. They can expect that viral infections last about 10 to 21 days and are usually self-limiting, right? We want to make sure that they know how to prevent infection, so wash their hands and that kind of thing. Cover their nose and their mouth when they're coughing and sneezing. We also want to support smoking cessation for our patients. So we should always assess our patients to make sure that if they do or do not use tobacco, so that we can update our plan of care to them. Okay. We need to understand as nurses how to motivate as well as provide information for them on realistic smoking cessation. Okay. Positioning. This is super important. Okay, this is a great intervention for patients who are having respiratory issues. So an upright or an elevated position pulls the abdominal organs down, allowing maximum diaphragm and lung expansion. Okay, so what that means is if you are sitting there next to a patient who's laying flat and complaining of shortness of breath, the very first thing that you should do is raise that head of the bed. You put them in a high Fowler's position so that they can breathe appropriately. Okay. And you can do that at the same time that you're doing many other interventions. Okay. Just hold your hand on that button and do what you need to do, but you've got to get them into an upright position. Okay, semi-Fowler's or Fowler's position if they're really short of breath. They may even put themselves in a tripod position, which is where they kind of spread their legs, lean forward, and put their arms kind of between their legs. A lot of times that will help give them some relief. Incentive spirometry. So we talked a little bit about that, but what this is, it's designed to encourage patients to take deep breaths by reaching a goal-directed volume of air. Okay, so if you look at this picture to the right of your screen, this shows you exactly how to use it. So you've got some different, this is an incentive spirometer here. And you can see the mouthpiece. That's where they're going to put their mouth and they're going to suck in air. Take a big deep breath in, right? That's how they use this. They take a big breath in. You can also see the piston. So that piston is that big blue piece there at the bottom. And then you'll see a goal marker. So the goal marker is used to give them a goal so that they can do what they need to do and meet it, and then we maybe increase or decrease it as needed. Okay, but they always have a goal, and that's where they want to get their piston to go to. Okay, so what happens is they first of all, they breathe all the way out, and then they put their mouth on the mouthpiece, put their lips all around it, seal it, take a big deep breath in. And as they take that breath in, that piston will move up to up the number scale there. And they want to try to get it to their goal marker, and they want to hold it there for a prescribed amount of time. 10 seconds usually is what you see. And then they tell them to do it 10 times an hour is typically what I've seen on the floors, but it just depends, whatever respiratory works with them for. Okay. This incentive spirometer is the best for patients who are at risk for atelectasis. So atelectasis, remember, is the collapsing of those alveoli. This can happen from patients who've had abdominal, chest, or pelvic surgery, patients on prolonged bed rest, patients with history of respiratory problems, things like that. Okay, so that's kind of how we're gonna handle that. The IS also helps trigger coughing. This is a great thing. We want our patients to cough so that they cough up those secretions. Just make sure that we are documenting. Documented or it did not happen. Okay, that's what we always say in the nursing world. It didn't happen. It did not happen if it's not documented. Okay. And then aspiration precautions. So when we think about aspiration, I want you guys to think back to anatomy where you learned about the throat and how you have these different tracts in the throat. So you have your esophagus, and that is where your food goes to go down to your stomach, leads straight to your stomach. There's another tube though. It's like it's like the fork in the road. One side is the esophagus, the other side is going to be your trachea. And the entrance, your trachea goes all the way down to your lungs, but the entrance to the trachea has your epiglottis. So that's kind of like a little door that kind of shuts and opens, lets air in, but lets food and drink not go in. Okay. And that's a protective measure. Okay. So if anybody's ever had a drink of something and they start coughing like crazy, choking on their drink, and they say, oh, it went down the wrong pipe. It really did. It really went down the wrong pipe. And so what you did was you aspirated a little bit. So that's aspirating when food or drinks or saliva or whatever, something that's not air goes down into the trachea instead of the esophagus. Okay. So with that, anything that goes down into the lungs that's not air is at risk for sitting there and growing bacteria and causing pneumonia. Okay. So aspiration pneumonia is a very common thing, especially in the elderly population. So we put people on aspiration precautions when they're at risk for this. So decreased level of consciousness patients with a diminished gag reflex or diminished cough reflex, or difficulty swallowing type patients. Typically stroke patients you'll see this with. We should always keep a suction set up and available for routine and emergency use. And that's kind of the deal with that. So we'll talk more about that when we get into lab as well. So more interventions for us. So we want to mobilize their secretions. What this means is we want to get their secretions, their sputum, their coughing stuff up. We want to get that out. Okay. Coughing promotes deep inhalation and forceful expulsion of secretion. So we want them to cough. Okay, so deep breathing and coughing, that's going to keep those air sacs in the lungs open, and it's going to help them cough out that, that sputum. Okay, well, that's what we want to do. Pursed lips. So we talked about those COPD patients, right? And how their drive to breathe is from those low oxygen levels and high CO2 levels. So chronic lung disease patients thrive in a high CO2 environment, right? It stimulates them to breathe. For this reason, we have these patients exhale through pursed lips, which is where they kind of make a kissy face with a little hole in the middle, right? And cough throughout their expiration. So while they're breathing out in short bursts when they do their deep breathing. This avoids high pressures that could possibly collapse those airways. Okay. Hydration is super, super, super important. So when you're hydrating your patient, it helps those secretions to thin out so that the client can cough them up more easily. Okay, that's one super important reason. I want you to remember that we as nurses can help enhance hydration as we wish. We can always offer more oral liquids to our patient, get them like things of water, multiple things of water, encourage them to drink. Okay. As long as they don't have an order where they're not allowed to have anything by mouth or something, we can always encourage them to drink more. Okay. Now we can also hydrate with IV fluids, but we would need a physician's order for that. Chest physiotherapy. So this is something that you'll see probably RT will do mostly. It involves chest percussion. If you'll see like a vest that kind of vibrates, what it does, it moves secretions to the large central airways so that they can either be suctioned out or they can be coughed out from the patient. Okay, and then oxygen therapy. Please check out the procedure 37-4 on page 1406 and 1408. Okay, look at all the equipment and look at the nursing responsibilities on that. Keep in mind with oxygen, it requires a medical prescription. Okay, it's typically ordered in liters per minute. So if a patient's on 4, they're getting 4 liters per minute of oxygen. Okay, typically when a patient is on oxygen for the long term, they have a humidifier attached. Okay, so that helps because regular oxygen with no humidity is going to dry out the nares and it's going to cause bloody noses and discomfort. Okay, so keep that in mind. There are a variety of different oxygen delivery methods. So if you even see this photo here on your slide, this shows you low flow systems. So those low flow systems can only take so many liters at a time. Some of them only up to like 6 liters at a time. So if you have a patient that's on like 10, 12, 15 liters of oxygen, you can't use a nasal cannula to give that. Okay. But you can use a Venturi system or an oxy hood or a face tent. Those are your high flow systems. Okay, so that's why it's important for you to review that table that I said, because you need to know how many liters of oxygen can go through each mask or oxygen delivery method, nasal cannula, whatever, so that you know what to apply to your patient. Because typically you as a nurse, you're going to be the one applying that. You have to go fetch it from the storeroom and apply it. So you want to know what to do. Okay. Other safety considerations with oxygen. Remember, it's highly flammable. So we have to keep it away from items that cause ignition, such as lighters, cigarettes, fireplaces, heaters, that kind of thing. Also, a less thought of complication of oxygen therapy is skin breakdown. So if you have a patient that's on a nasal cannula, there's going to be lots of there's ample time here for where the tubing rests behind their ears to cause skin breakdown. So I've seen it many times. And a lot of times people forget to assess that area, and there is skin breakdown there. Anywhere where there is pressure can cause skin breakdown. Okay, so that's something to be considered as well. So let's test your knowledge. So a nurse is teaching her client how to obtain a sputum specimen. In order to provide safe and effective care, the nurse instructs the patient to follow that the following action will facilitate obtaining the specimen. Which one? Limiting fluid intake, having the client take deep breaths, asking the client to spit into a collection container, or suggesting to the client that the specimen be obtained after eating. So the correct answer here, I will tell you in just a moment, but let's talk through this NCLEX style question. Okay. We know from this question that we want to obtain a sputum specimen. Okay. Which action will facilitate obtaining the specimen? Okay. Is limiting fluid intake going to facilitate it? No, it's not, because we know that providing fluids and encouraging fluids is going to thin their secretions. Okay. So really giving them extra fluids would probably facilitate it, right? And you're almost never going to limit fluid intake with a respiratory illness. We want to encourage fluids with this kind of illness. Okay. Having the client take deep breaths. Okay. I think that is a good contender. Asking the client to spit into the collection container. Is that what we're going to do? No, because remember, spit and sputum are 2 different things. Okay. When we are collecting a sputum sample, we have them take super deep breaths, ding, ding, super deep breaths, and then they cough, so that deep cough, that vigorous coughing, gets that sputum up out of their chest and into our collection container. Okay. And then suggest the client get the sputum sample after eating is not correct, because the best time to obtain a sputum sample is in the early morning. Okay, so the correct answer, have the client take deep breaths. Okay. Just a little overview on artificial airways. So you can see over here to the right, I'm going to go through all of these. So these are 3 different airways. You got oropharyngeal, nasopharyngeal, and an endotracheal tube. Okay, so we're going to go over those real quick. So the oropharyngeal airway, remember, these are for patients who are not breathing effectively on their own. Okay, so oropharyngeal. This is for use in an unconscious patient because it's likely to trigger gagging, vomiting, and that kind of thing. And so it's very uncomfortable for patients who are conscious. So we want an unconscious patient for an oropharyngeal airway. As you can see, it goes right into the mouth and just goes right down into that pharynx. Okay, and that's about as far as it goes. Pushes air right down to that, and then it just stops right there. And the air makes it into the trachea. Okay, it's a C-shaped, it's hard plastic, and you can get it in a variety of sizes. And that's it for that. So then your nasopharyngeal airway. This is a flexible rubber tube that's inserted through the nostril into that pharynx. Okay, again, stops at the same spot right into that pharynx. These can be tolerated by patients who are semi-conscious because they don't stimulate the gag reflex. Okay, again, available in a variety of sizes with these ones. And then lastly, an endotracheal tube. So these are pliable tubes that are inserted into the trachea. Okay, these ones are in the trachea through the following routes. So you could have an orotracheal tube. This one goes from the mouth into the trachea. This is the most common way to intubate a patient. There's also nasotracheal tubes from the nose into the trachea. This one's very rare. I've never seen it in my career, but it does exist. And then there's also a tracheostomy tube. Okay, so with a tracheostomy tube, this is a surgical opening right in the middle of the neck, really. It goes right into the trachea. Okay, there's several different kinds of tubes made by various materials. And all of that. And you guys will learn a lot about tracheostomy tubes in lab when we cover that, because you guys will have skills on tracheostomy cleaning and tracheostomy suctioning. Okay, so that's kind of what a tracheostomy is. And so it also is our intervention to suction the airway if needed. Okay, so with our artificial airway, whether it's an endotracheal tube or tracheostomy tube, or we're just suctioning, right, oral suctioning, just right inside the mouth, that's a thing as well. So suctioning is important to keep the airway patent, okay? We want to prevent the oral and nasal secretions from entering the lower airway when the patient's too weak to cough up those secretions. So it's important, if they can't do that work on their own, we need to get it out, okay? So suctioning the pharynx, this triggers a cough, which helps loosen and mobilize those secretions, okay? There's also the trachea may also be suctioned. So I want you to consider that pharyngeal suction is not a sterile procedure, but tracheal suctioning is a sterile procedure. Okay, it's very deep suctioning, and it's a sterile procedure. Okay, so you're down there in that lower airway, and we don't want to get pneumonia, right? So that's why it's sterile. So key things to remember when suctioning, and again, we'll go over this a lot in lab because you will have to perform this skill. So remember when you're suctioning that patient cannot breathe, okay? And that suction that you're putting in their throat can cause damage to their airway. So it's important for you to think about the suction as a vacuum. When you go down there, you are honestly taking their breath away with that suction. So it's super important. So we always want to pre-oxygenate our patient. That means give them some oxygen, a couple breaths of oxygen to build them up before you go down there and steal their air away, so that they have a little bit of a buffer. Okay. You always put the suction down into their into their airway, and then with no suction. And then when it's time, you come back up, swirl around, and apply the suction on the way out. Never on the way in, only on the way out do you apply suction. Okay. And we're always going to limit suctioning to 15 seconds. Okay. Because we want to give them time to recover, because it does take their breath away. Okay. And these patients already have respiratory issues to begin with. So suctioning is a pretty big deal. So when we're talking about delegating suctioning, the only type of suctioning that can be delegated is oral suctioning. And that means putting a suction into the mouth, and that's it. So if it goes into their pharyngeal area, if it goes into the tracheal area, they cannot do that. Okay, so that's important to know. This is just a reminder, refer to the procedures 37-5 and 37-7. This covers the tracheostomy care and suctioning. Those are the skills that you will learn in lab that we will do. Okay. And then this is just a picture of different kind of tracheostomy tubes. Okay. And we'll go over those in lab as well. All right. So talking about mechanical ventilation. So with mechanical ventilation, your patient has to be intubated first. Okay. Then they're hooked up to a ventilator. FYI, patients with long-term mechanical ventilation needs, they will receive a tracheostomy. We don't want to keep them on a long-term endotracheal tube. That's just opening at the risk for infection. So then they just do a surgical procedure if it's going to require a longer period of time. Okay. It's more comfortable and easier to replace if it becomes dislodged, doesn't require any sedation once the tracheostomy is healed. And it can heal, can be taken out if they get better, it can heal and they can get rid of it. Okay. There's a variety, negative pressure ventilators, positive pressure ventilators, monitor settings. These are things at the fundamentals level that you don't need to worry about. So we're going to skip past this, but you just need to know that it exists. All right, test your knowledge. So in caring for a client with a tracheostomy, the nurse would give priority to the nursing diagnoses of what? Okay, so breaking this problem down, we are looking for a priority, okay? It looks to me, reading through these, so A, risk for ineffective airway clearance, B, anxiety related to suctioning, C, social isolation related to altered body image, and D, impaired tissue integrity. It looks like they all apply to our patient. Okay, they just got a tracheostomy, which is that surgical procedure in their neck. So yes, they're going to have a risk for ineffective airway clearance. Yes, they probably have anxiety related to suctioning because that's scary. Yes, they have social isolation by altered body image because they have a surgical wound in their neck. And yes, impaired tissue integrity, they just had an operation. So yes, they have that too. This problem, this question is asking for a priority. Okay. Go back to your ABCs of nursing, your ABCs of healthcare, your ABCs of NCLEX questions, and your very first pillar is airway. So that's how we get the correct answer here of risk for ineffective airway clearance. Okay. What's going to cause our patient harm? It's that one. Okay. All right. Thank you.